So now we're going to move over into the field of light therapy. So light can, with certain parameters, assist with regenerating tissue and reducing inflammation and pain. And James is there. So James, I understand that you and I are probably about 5 miles from each other while everybody else is on mostly in America. Oh, you're on mute, I'm afraid. Can we unmute James, please?
Now is that better?
Yeah, great.
Good. Are you ready?
Let's go.
Okay, so I'm here to introduce you to photobiomodulation, if you haven't heard of it before. Brief insight into its effect on mitochondria and how that affects degenerative disease and health span. So this is something everybody's seen on TV, you know, on Star Trek, when somebody gets injured and they go to the sick bay, the doctor gets out a laser, aims the laser at the injury, and the injury heals instantly. So we make those. Any questions? All right, I'll continue then. Our device at the moment looks like this, has lots of different accessories that we can plug into it, more than you can just see here. We've got helmets, we've got things that go into dark corners of your body, and we apply it to patients like this. It's a handheld device here with a console that drives it. For the field of photobiomodulation, there's more than 700 randomized placebo-controlled clinical trials published in this field. There's more than 4,000 laboratory studies looking at the mechanism of action and the dose response. There's more than 500 papers published last year. Already this year, 444 as of yesterday. So it's on target to exceed last year by at least 10%. More than 7,000, well, I mean, getting on for 8,000 papers in total. And for our own product, we've delivered 30 million treatments to date. How does it work? We don't have time to get into it, but it seems to a lot of the effects that start off in mitochondria and specifically at cytochrome C oxidase, the terminal enzyme of the electron transport chain, also known as complex 4. It's known to regulate ATP production, but when we're sick, injured, stressed, or just old, our cells tend to be low on ATP. They tend to be high in oxidative stress, and cytochrome C oxidase likes absorbing certain wavelengths of light. And when we put this light in, it takes stress cells and tips the balance in favor of more ATP and less oxidative stress. And under these circumstances, patients will heal more quickly. And there's a bunch of biomarkers here you might be interested in. If you know your NF-kappa B pathway, it's NF-kappa B is sometimes known as the master switch for inflammation. And so we reduce NF-kappa B activity and its translocation to the nucleus, and we have an effect on AP1 as well, which is the gene associated with tissue regeneration, cell survival, and organism lifespan. Wish we had more time to talk you through all of this and how it ends up repairing tissue, reducing edema, inflammation, and it has an analgesic thing as well that it can do. I just want to show you some clinical evidence from that. So oral mucositis, a side effect from high-dose chemotherapy and radiotherapy and bone marrow transplants. Now, bone marrow transplants get the worst. This is hematopoietic stem cell transplants here. The 5 grades of oral mucositis on the WHO scale. Most of these patients get severe oral mucositis. Only one in this study who had the photobiomodulation patient got oral mucositis. The rest of them, well, you see in the control groups, there are mostly 2, 3, and then most of them in 4. Photobiomodulation groups are mostly 2, 1, or none at all. This is a highly anti-inflammatory treatment wherever you put the light. And at the University of Pittsburgh Medical Center here, they've shown that they reduced the incidence of grade 3 oral mucositis. Remember, it goes grade 3 and grade 4. They reduced it from 40% down to 10.5% since they implemented our treatment there. Here's some before and after treatments for oral mucositis. These patients often can't eat. They have to be fed by a tube. This is radiation dermatitis, where the radiotherapy goes in before and after. Dry mouth, because the radiation damages the saliva glands, so that's a problem. But this was done therapeutically, and it works even better if you treat before they get it. There's something we can do to healthy tissue to improve its resilience. It's been shown many times in the lab, and now we've proven it in clinical trials as well. This is a reaction to having a bone marrow transplant, the stem cell reaction from a donor here, this GVHD, graft versus host disease. Nothing really solves this except we do. Look at this, it's receding. That's after 8 treatments, 1 treatment a week over 8 weeks. It really should have been twice a week. It would have been better. These are kids at Boston Children's Hospital here getting treatment transcutaneously through the cheek into the buccal tissues and through the labial tissues as well, and treating lymph nodes. We stimulate the lymphatic system here in cervical lymph nodes as well to help drain inflammation. This is all part of a feasibility study for a much bigger experiment that's coming up. We're collaborating with many cancer groups all over the United States on these projects with various side effects from radiation and chemotherapy. And already American insurance companies have declared it medically necessary for patients at risk of developing oral mucositis. And the Multinational Association for Supportive Care in Cancer recommend this treatment for cancer patients. And NICE, the National Institute of Health and Care Excellence in the UK, that recommend treatments to our National Health Service, also recommend it as well. Diabetic patients, I'm sure we've been talking about that a lot recently at your conference. This diabetic patient had a hernia operation. A year later, it hasn't healed. He's at Rochester General Hospital. They project our light onto his wound. And then 2 months later, you can see there's good signs of healing there now. There's some small studies in diabetic wound healing in humans showing increased healing rates in the treatment groups compared with controls, increased granulation tissue compared with controls, just projecting our light on there for 1 minute per area. Knee osteoarthritis, obviously a problem with aging. Systematic review published in the British Medical Journal, 22 randomized controlled clinical trials, 1,063 participants in all. At the end of a course of treatment, pain reduction is 18.7 millimeters on the visual analog scale. Compare with that with non-steroidal anti-inflammatory drugs. For most musculoskeletal pain is 7 to 14 millimeters reduction. We're getting 18.7 with photobiomodulation. And when you stop treatment, there's this healing cascade that continues going, and the pain relief increases to 23.2 millimeters. And there's this magic moment between 2 and 4 weeks at the end of after the end of the study, when it goes up to 31.8. This is huge in terms of pain relief. Disability also statistically significantly reduced. The positive effects of PBM lasted longer than widely recommended drugs. I mean, significantly longer. No adverse events reported, not just in this review, but consistently across the field of photobiomodulation. Post-hepatic neuralgia is one of the worst kinds of pain that you can get. People can't wear shirts, they can't lie down, they can't bear to be touched. It drives people to suicide. That's unfortunately not uncommon. In this study, patients who've had PHM from 6 months to 8 years, mean duration of 2.5 years, are going to get treatment once a week for 4 weeks. And in the active treatment group, you see the pain comes down. In group B, there's no significant change. It's a crossover trial, so group B then get the active treatment, and the group A go on to the placebo treatment. And notice their pain doesn't get worse. This has a long-sustaining kind of pain relief. So I'll explain why later on. 95% of patients in this study discontinued all medication for one of the worst kinds of pain that you can get. 5% required a reduced dosage. 16 patients, that's 80%, maintained their pain reduction at 6 months. 2 returned to a pain score of 4, not requiring medication, and just 2 patients went back to pain scores of 6 and 8. Not bad for one of the worst kinds of pain you can get, which is something you really begin to, when you start hitting 70, instead of getting like a rash of shingles for a couple of weeks, this is really persistent and can stay with you for the rest of your life. The Lancet, the world's leading journal for breakthrough medicine, published a systematic review on chronic neck pain, a review of 16 randomized controlled clinical trials, 820 subjects in all. They show that photobiomodulation reduced pain intensity, reduced disability, reduced recurrence. The mean pain intensity reduction over placebo is 23.4 millimeters. Remember that non-steroidal anti-inflammatories get you between 7 and 14 millimeters of pain relief, so 23.4 is good. It's the world's leading journal for breakthrough medicine. Is that the reason they published this? No, it's not. The reason they did it is because there is no licensed drug on the planet for neck pain, for chronic neck pain. There is no drug of any kind licensed in any country in the world. That's why it's in the Lancet. This is a medical breakthrough. This is a heart after a heart attack in a rat. They've occluded the coronary artery, then they reperfuse the heart. You always end up with scar tissue as a result. But if you project this photobiomodulation through the chest of the rat into the heart, you see less scar tissue. Easy to do on rats, they're small, humans are too big. These authors discovered that when you put laser light into the tibia, into bone marrow, it releases mesenchymal stem cells into the bloodstream. In healthy human studies, they go up by 300 to 500% after one treatment. And some of them are still statistically significantly elevated 2 weeks later. Putting light into your tibia, stimulates the release of stem cells. In a human clinic, by the way, number of mesenchymal stem cells in the heart of a rat on an untreated control. If you treat the heart directly after a heart attack, you get some more stem cells. If you treat the bone marrow, you get even more stem cells arriving in the heart after a heart attack. What effect do they have on the infarct size? There's the infarct size in control. There's the infarct size if you treat the heart directly. That's if you put laser light into the bone marrow. You get this profound reduction in infarct size. They got the same result in pigs that have done a human clinical trial now. I haven't got time to walk through all of it. There's 24 ST elevated patients here receiving primary percutaneous coronary intervention. And whilst there's no statistical change, I mean, it's 56% there, didn't quite make significance in creatine kinase, but troponin T did reach significance in this small study on 24 ST elevation patients after a heart attack, which is a big deal. This treatment is highly anti-inflammatory. This is an experiment on a Biodex machine where volunteers do 5 minutes of exercise on that machine there, then they get 20 minutes of ice therapy or cryotherapy on their bicep, or 30 seconds of our treatment, or ice plus light, or light plus ice, or a placebo. And they're going to do a blood test before and after, and they're going to do at a 1 hour after, 1 day after, 2 and 3 days afterwards. So these are the blood test results. Creatine kinase, the photobiomodulation group, are pretty close down to baseline compared with all the other groups. Placebos, ice therapy, cryo plus light, light plus cryo. Photobiomodulation got the best result. Delayed onset muscle soreness, pain on the visual analog scale here, showing all the groups with photobiomodulation are significantly lower than the control groups and the cryotherapy group. And maximum voluntary capacity, that strength in Newton meters here, all the groups that had photobiomodulation are back to full strength within 24 hours. Compare that with people who don't get it. If you're a professional athlete or an enthusiastic athlete, this is a very important effect. And it was used by the Nike Oregon project in Rio at the Olympics, and they came back with more medals in the middle and long distance running group who used our technology than any year previously. And that's why it's being used by all of these groups, including US Navy SEALs and Special Forces. And it's also in the US government, GSA and ECAT catalog. So institutions that are part of the government, like the military, can just buy them as much as they like. Dry age-related macular degeneration is the leading cause of blindness in the developed world. There's two kinds, there's wet and there's dry. 90% of patients have the dry form, and that's the untreatable form. The wet form, you can have injections in your eye to slow progression. If you don't have AMD, you can see 4 kids in my kitchen. But if you develop AMD, you lose central vision, you get distortions in your vision and this blurring kind of effect. You lose contrast sensitivity, you develop these blind spots called geographic atrophy, which get worse until you can't drive, you can't read, you can't enjoy watching TV, you can't go shopping, you lose independent life. It's a huge cost to social services, and there's nothing you can do about it if you've got the dry form. I'm a co-founder and investor in Lumathera. They've raised $21 million to date. They are open to having more. They did a pilot study, which I'm going to show you some results from. 30 dry AMD subjects, 46 eyes in total. I know there's 60 eyes, but only 46 had AMD in a small randomized controlled trial, which we did 3 times a week for 3 weeks. They got a second course of treatment of 6 months, and then they did the 12-month follow-up. And you get this improvement in visual acuity. Nothing else does this in dry AMD patients. This is a whole line on the ERTDS chart. That was a high vision early stage group, late stage patients, much slower progression, but still they have nothing else that works. Now we have something that works for that. And there's 16 randomized controlled clinical trials run by Lumathera right now, 8 in Europe, 8 in the United States. And there is, I don't know what kind of investment they're still looking for. You can go to lumathera.com if you want to find out about this. This is the retinal scan here, optical coherence tomography. These are the drusen, which are the hallmark of this disease, and they're going away. So in conclusion, here it's non-invasive, non-toxic, non-addictive, no known side effects. The relief that lasts longer than drugs. And it does this because it helps people heal. Our goal is to have this established as a first-line medical treatment in 100 diseases in 100 countries. By the time I'm 100 years old, interim goals are 10 diseases, 10 countries, 10 years, 3 diseases, 4 countries, 5 years. It's where we're going is our goal for it. We're self-funded. We were in 5,000 installations, 72 countries, FDA, CE, and TGA, cleared NATO, GSA, NECAT catalogs. 10 million in revenue last year. Average growth was 25% for the last 10 years. The current growth will be at $1 billion sales by 2042. We're profitable 9 out of the last 10 years, 10 to 15% EBITDA, and we're not looking for money, though we are interested in orders and academic collaboration. It works wherever you apply the light, so we made a system that treats your whole body. That's why it's with all those teams. That's all, folks.
Wow, very good, James. And how did I know you were going to finish bang on 15 minutes?
Didn't have a choice.
No, that's great. Well, we're going to stay on track. So I think the best thing, James, is there's going to be a ton of questions to be addressed. So we're going to ask you to take those in the breakout room, if you don't mind.
Absolutely.
And thanks for a really good presentation. That was great. Thank you.
Right. Thank you. Thanks, Thomas and Phil.
Awesome.
Bye-bye.